turn that on. There we go. My name's Kelly Knott. I'm with Elevate Wellness and Physical Therapy. I'm beyond excited that you guys are all here, and the powerhouse of women I think that we have presenting with you today. We were just talking before, like, so happy that people want to have this conversation. This conversation has been in the dark far too long. We've been suffering for far too long. Ellie and I were thrilled that the FDA took the warning labels off of estrogen this week. We couldn't believe the timing of that. We're like, yes, here we are already scheduled, and it was so good to see that change. So I'm going to give you guys a little bit of a spiel of my life as a pelvic floor therapist and kind of how I address some of these symptoms. Ellie has been a provider of mine for 2 years, and she changed my life is really the best way I can describe it. 7 years of, what is this weight around my belly? Why am I so tired? I used to be an endurance runner. Why can I go run 3 miles and not move for 3 days now? Like, what is going on? When did my husband start breathing that loud? You guys know, okay? Sorry, Kevin, you're outnumbered today. We invited the men. Kevin was the only brave one to come, and my husband. So you guys all know what I'm talking about. My poor kid, okay? I'm an older mom. I had my daughter at 42. My sweetie's sitting back there. She's only 8. And I'm like, what is this rage that has suddenly showed up in my life from a pretty, I think, chill person normally? I went to my primary care. I went to numerous providers that told me, you're just an older mom, you work full time. It's devastating, right? Who else in the room has had that happen, right? And then Ellie started advertising. And I went to her, and I'm good to go, Mike, right now. So, oh, you found pens, amazing. We have pens if somebody needs pens.
Amazing.
And just quick intro, this is my husband, Mike. He is the director of the retreat center here, so we can thank him for the space offered to us today. It's good to have a connection for a beautiful space like this, so we appreciate that very much. But so basically, I think that's a similar story for a lot of folks in this room, is you kind of, and it's not that the doctors weren't nice or didn't have my best interest at heart. They're just not educated. I believe I have it on one of my slides. It's something like 5% of gynecologists actually feel comfortable treating menopause. 5%, okay? There's no education provided in medical school. So it's not really their fault. You know, it is out of pocket. Ellie will tell you, we've both spent a lot of money on our free time to go to courses to get this education that we are screaming from the rooftops to share. So I'm so thrilled that you guys are here. Please be interactive with us. This is a lot more fun when you ask questions. I know if you have the questions, somebody else in the room does as well. There's no dumb questions, especially on this topic that none of us have been educated on. So please ask away. I just started a new business here in town. There's a common theme among the 3 providers in the room today. We kind of all defected from the traditional medical model because we want to treat patients like we want to for as long as we want to. Ellie often has 2-hour appointments, right? So I do evaluations that I schedule them for 75 minutes, but they're usually an hour and a half to an hour and 45 minutes, just because we want to give you the attention that you deserve and hear your stories and hear what's going on, and hopefully fix it on the line. So we have cards and everything on the table for contact information, so I won't spend too much time there. So I already hinted at a few of these. Any of these sound familiar to anybody in the room? Disruptive sleep. No wonder we're so angry, right? We're getting 2 hours of sleep a night, waking up with hot flashes, waking up with urinary urgency and frequency. You know, maybe you used to sleep through the night, and now you're getting up 2 or 3 times a night. UTIs, maybe never had them in your life. All of a sudden you start getting UTIs. Mood, anxiety, we talked about. Anxiety for me was through the roof. It was my most prominent symptom. And I've never been anxious in my life, so I did not know what to do with that. And I was initially put on an anxiety medication, which Ellie educated me that probably contributed to the 30 pounds that I gained because it slows everything down, right? Gut motility, fatigue, my desire to exercise, things like that all went out the window along with it. Painful intercourse, lack of libido, changes in menstruation. So this is a fun one. Periods can be longer, they can be shorter, they can be more frequent, they can be less frequent, they can be super painful. Anybody that worked with me before I saw Ellie, I'd be in the clinic and I'd all of a sudden go, ooh! And I just told people an ovary was dying. I mean, that's what I presumed was. I never had cramps in my life and was having horrific pain for no particular reason, right? Brain fog, that was another favorite of mine. I did not know how much brain fog I had until the clouds lifted and it was like, oh, I'm not stupid anymore. I can complete my notes at the end of the day. It's really, this is one that really takes successful women out of industry. You've been productive, promoted your whole life, and all of a sudden we hit about my age and you're like, I can't remember anything. I don't know why I'm here. I don't know what I'm supposed to be doing. Words were always really fun to find. I'm trying to educate my patients, and I'm like, the thing, it's like it runs from here to here. I mean, this is what happens, okay? ADHD, if they diagnosed it when I was a child, I would have had it. It gets really fun in perimenopause. It comes back. So all that good management that you've done throughout your life to kind of calm that down comes back with a vengeance when we hit perimenopause here. And weight gain, everybody's favorite there too. So when you get gaslit by your doctor and then you learn perimenopause can last for 10 years. Okay, so the onset of symptoms to menopause is often in that 10-year time frame. It can start as early as your mid-30s and as late as later in your 40s. Some folks have no symptoms at all and go, I handled this without any medication or hormones. I don't know what you need. Anybody hear that? Okay. And then, like we talked about, periods are all over the place. Hormones fluctuate. So I think it's a common myth that you just suddenly lose estrogen. It's actually more like we go back to puberty. And the hormones are wildly fluctuating. So loss is a part of it, but there's also big swings. And Ellie will deep dive into all of this. So you are considered to be in menopause after 12 consecutive months of no periods. It's considered early menopause if it's under the age of 45. If you're looking at under age 40, it could be due to ovarian insufficiency. The current age is typically about 51 for the onset of menopause. And that's been really consistent. That's another interesting thing that hasn't changed. The same age of onset in 1900 was 51. Difference is we only lived to about 54, and now we live until hopefully 80s and 90s, and so we're going 30 and 40 years without hormones as opposed to 4 or 5. So that might be why we're screaming a little louder than generations before us have. And then they consider it surgical menopause once the ovaries are removed, if anybody's had any of those surgeries. This year, there are 1.1 billion women in menopause. Should we pay attention to it? Yeah, maybe. So I said to over here, there might be a little tone of like antagonizing when I talk, and there's a good reason for it. So why are we not treating menopause? Here are your health risks that come along with it. Diabetes, huge uptick, okay? Heart disease. Heart disease is the #1 killer of menopausal women. We are higher risk than men once we are menopausal. It's huge. Why wouldn't we do something to treat that, right? Urinary tract infections. Everybody in this room's probably had one at some point. Typically when you get normal symptoms, increased urgency, painful urination, burning, it's easy to know you have a UTI and to get care for it. Still requires a doctor visit, antibiotics, things along those lines. When you get older, often those symptoms are very different. It might be confusion to start with. It might be, back pain, shoulder pain. It doesn't always show up as a UTI. And that could quickly turn to sepsis, which is, I'm sure people have heard that term, typically a hospitalization, and it's very deadly. So UTIs are deadly. So that's something that we want to try to prevent as well. Dementia, another risk of menopause. Dyspareunia, so that's painful insertion into the vagina. So intercourse, dilators, things along those lines. Osteoporosis. I can talk to you guys for 2 hours about prevention of osteoporosis and the hormonal connection. And this, yeah, here's my stat. I was a point off here. So 6.8% of students in medical residencies feel comfortable treating menopause. So hopefully med school is changing in the near future. I'm not going to dive into this too much because I think Ellie's going to, but again, you guys were a great first conversation here. So here's a perfect example. Do you mind me using you as an example what you just told me earlier? So she said early on when she went into menopause, she was put on hormone replacement therapy. No questions asked, just right up front. Then this research paper came out and you were taken off hormone replacement therapy. The actual study itself wasn't horrible, but the interpretation and some of the data collected was where the issue lied, okay? The part of the issue with the group that they looked at was that they were 35% were considerably overweight, 34% were obese, 36% were already being treated for high blood pressure, and nearly half were current or past smokers, okay? And the median age was 63. So you'll see that kind of ideal time frame for getting started on hormone replacement is usually within 10 years of the onset of menopause. So this group was older than that as well. So the data we were collecting was from a flawed audience as well. So that's where you got some of the bad data from that study. And then what was interesting, even though this pretty much stopped any provider from providing hormone replacement therapy, folks that were in the estrogen-only replacement group actually showed a decreased risk of breast cancer. So, right? Okay. This position is so this is where I get a lot of my research and data from, the North American Menopause Society. You can Google them for any article you could ever want, their latest data on, there's good research. We need a ton more on women in particular. But there's really good information here. Still remains the most effective treatment for vasomotor symptoms. So what are those? Those are your hot flashes and things along those lines. And the genitourinary symptoms of menopause, and has been shown to prevent bone loss and fracture. All right. This is one of my favorite studies. I kind of had to expand it so that you can see it, so it might be a little distorted there for you, but this was out of the UK. This is looking at women aged 50 to 59, and we're looking at groupings of 1,000 women, okay? So and this is following these folks over the course of 5 years. If we look at 1,000 women aged 50 to 59, in 5 years, we have 23 of them will have breast cancer. That's just fact. That's away from hormone replacement. So this is just the general population. An additional 4 cases we may see with combined hormone replacement therapy. Are they folks that were going to get breast cancer anyway? Is it anything to do with the hormone replacement? That's not determined here, but we're looking at 4 people. For fewer cases for women on estrogen-only hormone replacement, okay? An additional 4 cases for folks put on the pill. Anybody in the room ever put on the pill? I was prescribed for 20 years. Nobody ever said there was any risk, any increased risk of anything. Anything over like 4 or 5 years on the pill is considered excessive. Nobody ever mentioned that either, so we'll see what happens down the road. But I think it's interesting that the pill causes an equal number of breast cancer, and none of your doctors have ever hesitated to put you on the pill. Okay. Notice that tone again? Sorry. This one should come with the warning label. Anyone who drinks 2 or more alcohol beverages per day, there's going to be 5 more cases. So there's like a 25% increased chance of breast cancer just from drinking alcohol. Okay, it's the worst, I think, of some of them, but nobody's probably ever told you that either. An additional 3 cases for current smokers, 24 cases for overweight or obesity, and then 7 fewer cases for women who do at least 2.5 hours of moderate exercise per week. So can we handle some of that? on our own, right? So some of this is really easy. Don't drink, don't smoke, and exercise a little bit. It's going to really decrease your risk of cancers down the road. HRT has been shown to be cardioprotective. The increased frequency of hot flashes has been linked to increased risk of disease, cardiovascular disease by 50 to 77%. So everybody's seen the memes. One of my favorite is the lady sitting on the bleachers and the steam is coming off her head, right? And we laugh about it like it's one of these rites of passage that we just have to go through. However, they are finding very strong links that if you have a high frequency and intensity of hot flashes, it really increases your risk of other comorbidities there. I think I talked about most of all of that. My bottom one I love. Estrogen is the only proven method of reducing bone loss after menopause. Okay, huge. So I'm a PT. My poor folks that have hip fractures and then come to see me for PT don't like me very much. It's a very painful injury, very difficult recovery. The mortality rate linked to hip fractures is enormous. I wish I had the direct quote on that, but I think it's if you are above 70, mortality rate in the first year following a hip fracture is like 25-30%. It's really high, really high. So this is my realm here, genitourinary symptoms of menopause. These all sound so wonderful. Burning, itching, dryness, spotting, pain during sex, need to pee often. Before menopause, your vaginal wall is thick, stretchy, and has more fluid. After menopause, your vagina is shorter, the wall is thinner, less stretchy, and has less fluid. So why don't we want to have sex anymore? I don't know. Kevin, tell the men.
I'm just a fly on a wall,
Okay. You know? You're not here anymore. So again, Ellie's going to deep dive into the hormones. I did want to talk about the topical aspect of estrogen. Any primary care provider in town knows me from sending my patients to them to request topical vaginal estrogen. Topical vaginal estrogen should be given to you as soon as you have the onset of perimenopausal symptoms. And as I've heard quoted, they should pry it from your cold, dead hands. That's how long you should be on it, okay? It should be just standard of care. Topical estrogen will add back blood flow, moisture, plump up that tissue. So if you are struggling with any of the burning, itching, frequency of UTIs, and UTIs, it is shown to change the acidity of the vaginal tissue and prevent UTIs. So I think it's $25 billion a year is spent on treatment of UTIs. So that's doctor visits, antibiotics, hospital stays, sepsis. So if we just gave you topical estrogen, we could probably cut that down to under $1 million. So that's Medicare dollars. So why is Medicare going bankrupt, right? This is my pretty illustration of your vaginal tissue. I would say this isn't even totally accurate, but you'll see on the right, so thinner, flatter, usually even flakier and whiter tissue is often what I see in practice. If we use topical vaginal estrogen, we get that redness, that plumpness, that rugae reform. So it just equates to a lot more comfort for the gal. The good news, there is some, right? So happiness usually improves 2 to 3 years after menopause. So once you are menopausal, things start to get better. Life satisfaction improves. We have greater empathy, greater emotional control, which I always find funny because, yeah, I'm a little irrational at times. Increased self-transcendence, more efficient brain, and memory actually improves once we finally get those 10 years gone and into menopause. How many people get divorced in that time? How many people have increased suicidal tendencies during that time? I mean, this is a big deal. And there's help, and we just are not getting it so far. Factors we can control. I already mentioned a few of these: exercise, diet, limiting alcohol, social interaction, meditation. I always laugh. I'm not any good at meditation. You know what that means? I need it. Okay. And I say this to a lot of my patients and they laugh when I mention it. Good news is there's a lot of different kinds of meditation. Some of them are quite active, like you can actually do a forest walking meditation, which is a little bit more up my alley than trying to sit there in a quiet room and you know, go inside myself or something. I can't do that. Stress reduction and sleep modification. Some non-hormonal regulation. So if you are not a candidate for hormones, there are other things that we can do. On this list, the cognitive behavioral therapy, per the research, is the most effective means of treating why am I going crazy, right? So it's really high on the list in terms of treatment. Melatonin for sleep, magnesium. Magnesium is known to have a calming effect. A lot of people also use it for constipation. It helps with gut motility, sleep along those lines. Mindfulness. I think Ellie's got a whole bunch of slides on DHEA and hyaluronic acid, which is be right up Susan's alley. So, breathing, huge. This is the easiest way to tap into our central nervous system. This is something I'm gonna have y'all try, and it'll help me calm down a little bit too. So your diaphragm and your pelvic floor move in sequence together. So when we talk about leaking and lifting, okay, what do we tend to do when we go to lift something heavy? Right, we hold our breath and bear down. When we hold our breath, our pelvic floor also lowers, puts more pressure on the bladder, is weaker in that position. So that's commonly why we leak during lifting activities. So if we can do good deep inhales and exhales, we're actually moving that pelvic floor into activation and relaxation. So just by breathing, you can exercise your pelvic floor. So here we go, guys. We're gonna all inhale for 4 seconds. And then exhale for 7. It's a long time, right? Good, try one more for me. You do too many, you'll get a little lightheaded, especially at this altitude, but 3 to 5 at a time are really good for calming that central nervous system. So when you're about to come out of your skin, this is a great practice to try. I put a few of my favorite books up here on the front table, that yellow book, Breath. Oh my goodness, if you want to deep dive into breathing, I read the book, I think 3 times, and then I listened to the audio book at least 3 more. And then I listened to every podcast that guy was on. It's fascinating. And I think it's in that book too that they used to say way back, or even in some of the yogi populations, when you look at a respiratory rate, which they always mark down on your chart when you go see the doctor, it's usually like 16 or 17. It used to be, or should be, somewhere like 5 to 6. So that'll tell you kind of how quickly and shallow we've kind of become accommodated to for breathing. You know, stress might have something to do with that too, right? So other alternatives to non-hormonal, so SSRIs, SNRIs, so these are your anxiety, depression medications. That's usually the first line of defense by most primary care providers. First thing Ellie did was get me off that medication, which was interesting, if anybody's ever been on those. I almost took a leave of absence getting off that medication. It was so hard on my brain. Gabapentin, people have heard of that, known as a nerve medication, has been shown to be pretty good with the vasomotor symptoms. However, not an easy drug to take long term. And then oxybutynin is known for overactive bladder, has also been shown to contribute to those vasomotor symptoms. The neurokinins are actually antiemetics, so anti-nausea, vomiting drugs have also been shown to be helpful for some of those. Probably none of these which you'd really want to be on long term, but they might be able to get you over some of the humps. Questions so far? Nope. Okay. So what do I do as a pelvic floor therapist? I can tell you, when people first started coming to me with these symptoms, I was like, what's wrong with you? Like, what is going on? I didn't quite understand what was going on. It was only about 6 months later that I started experiencing some of this and understood very quickly. But all of a sudden people say, I have not changed my diet. I have not changed my exercise. I have not done anything different, no new medications. And I can no longer have intercourse with my husband. It hurts so much. I can no longer have, I can't sleep through the night anymore. I'm getting up to urinate all the time. I'm going every 1 to 2 hours during the day, like just sudden onset of these symptoms. So we work on partially behavior modification. And my patients always get mad at me when I mention that. And they're like, you're saying that's in my head. And I was like, well, it is from a neurological standpoint, not from a you're crazy standpoint. But some of these are just like urge management techniques for frequency of urination. Sometimes it's modifying what we actually ingest. So if we may have been able to drink a pot of coffee our whole life until we hit perimenopause, and then all of a sudden it's causing severe urinary frequency and urgency, things along those lines. We can work on strengthening if that's required of the pelvic floor, pelvic cavity, back, hips, everything along those lines. Down training is very common in this time. If you start leaking, guess what you do to your pelvic floor? We tighten everything all the time. And there is not a muscle in your body that can walk around tightened all day and be effective, right? It's going to fatigue like any other muscle in your body. So we actually work on calming down that nervous system, learning when you're activated, when you're relaxed. Dilator and manual work. I have my little table over here that has some of those on there. Pelvic wand, dilators, things along those lines. My table is also full of lube, so if you guys need any samples of lube, I know, you can't be a pelvic floor therapist and not laugh, but all these companies send me samples, so anything in the bins over there, please feel free to grab some samples to address that dryness issue that comes along with this time. Education, what we're doing today, we just don't know what's going on and are desperate for somebody to tell us about it. Skin hygiene, that vaginal tissue can get very raw and very irritated, so just better care for that tissue. Bowel bladder diary, so this is looking at what are we ingesting that may be causing some of these symptoms. And constipation, you could have been the most regular pooper your whole life, and then all of a sudden you're like, what happened? I cannot go poop anymore without straining, without delay, without being super meticulous about your diet. If one thing's off, you're wrecked for like 3 days is pretty typical or common along here. So looking at some of the most beneficial exercises, it needs to be a combination of high intensity weight bearing exercise, progressive resistance, so that could be TheraBands, that could be water, that could be weights, that could be any modality there. During this time frame, we most commonly lose shoulder range of motion and thoracic, so that's mid-back mobility. And the recommendation, this is has to be obviously tied into everybody and where you're at, but we're looking at the resistance training at least 2 times a week, 2 sets of 8 to 10 at 80 to 85% of a 1 rep max for each major muscle group. What does that mean? Okay, so if the absolute heaviest thing I can kick my leg out on a machine is, say 100 pounds, it wouldn't be 100 pounds, but let's just say that for easy math. We want to do 2 sets of 8 to 10 at probably about 80 to 85 pounds. So it's heavy, okay? I've learned recently as a PT, we are significantly underweighting our patients, as if we weren't mean enough already, right? But the literature is saying that we are doing a disservice, especially to our seniors, in not making them lift heavy. I don't know where we sort of got in that frame of mind that they're fragile and we can't do that. It's wrong. And they're going to be healthier and live longer and have a reduced risk of fracture if we actually really make them work lifting that weight. So I just wanted to throw a few exercises up here that are good for some of that mobility we were talking about. So thinking shoulder and mid-back. Bird dog, anybody's ever done a bird dog? You're lucky I'm not making you, we had too many people for me to make you get up and do all these with me today. Wall angels, this one, it just feels fabulous. You just find a bare piece of wall, kind of get your shoulder blades up against it, and we're just raising our arms up and down. So that's gonna address both the shoulders and the thoracic spine at the same time. This one feels great if you have a desk job. You don't even necessarily need a foam roller, but you can roll up a towel or even stick your jacket or something behind you and just kind of stretch and rotate that backwards. What's a common posture we see with aging? Everybody knows it, right? So these are all geared toward that as well. I actually threatened my daughter last night. She said, why do people shrink when they get older? And so we talked a little bit about some of the postural effects and decreased bone mass, things along those lines. This is another favorite, thread the needle, they call it. It's common in yoga practice. All right. Osteoporosis, real quickly, 1 in 2 women over the age of 50 will break a bone due to osteoporosis. Half this room in the future will break a bone because of osteoporosis. What puts you at higher risk? You're over the age of 50, you weigh less than 127 pounds. I think I weighed that in 3rd grade. Your BMI is less than 20. Smoking, huge. I'll never forget, as a PT student, being in the OR observing a total knee surgery, and the doc had a fit in the middle of the surgery and said, "Did this person smoke?" And they're like, "Oh no, it wasn't on her history." He said, "Her bones are mush." So, I mean, can you imagine he cuts into your bone to do a joint replacement? So what do you think her success was going to be with a joint replacement? So whether it was reported or not, who knows, doesn't matter. He already cut the bone off to see what was going on in there. So it has huge effect. Dietary deficiencies, minerals, vitamins, things along those lines. Early or surgical menopause, that maybe, sometimes folks have hysterectomies after childbirth. They're really young. So they're really at high risk for bone loss because of that loss of estrogen going forward. And then any estrogen blocking medications. So oftentimes cancer treatments, if it was an estrogen driven tumor, they will put you on estrogen blocking therapies. Horrible for your bone mass. So we got to weigh the consequences, but those are the folks that really need to get in the gym. And you've just had a cancer diagnosis, you might be in treatment. It's not usually the first thing that comes to mind in terms of corrective behaviors. And then just a little bit, so I put heavy on there, benefit, same thing, high intensity, weight bearing, progressive resistance. Jumping and plyometrics. Why, when we hit 40, do we quit jumping? It might hurt, that could be a big part of it. There was a recent study that showed if you were to stand on, please, your bottom step, not the top step, the bottom step of the stairs of your home, usually that's about 8 or 9 inches in height. And if you jump off onto 2 feet and then quickly jump back up, and you do that 10 times a day for the rest of your life, you're decreasing your risk of osteoporosis or increasing osteoporosis by about 8 to 10%. So that's something really, so every day when you come down the stairs, just go a couple times. You're getting that compressive load on the bones from jumping, and then you're getting that pull or that tug of the muscles on the bone by jumping right back up. So that's where plyometric exercises come in really handy.
So is that helpful once you've already been diagnosed with osteoporosis?
Yes. So as soon as you get diagnosed with osteoporosis, what they tell you, oh my gosh, don't fall, right? Don't do anything. That is the worst thing that you could do because you lose muscle mass, you lose that protection of muscles around your bone. Cardiovascular standpoint, right? You're not working out as much. So if you get a diagnosis of osteoporosis, come work out. that is the fix. And hormone replacement is huge to prevent further loss.
But you feel that the jumping isn't in any way?
It's, again, every person is individual. However, most of the time we're going to see those fractures in the femoral neck, where the hip enters that kind of ball and socket joint, and the spine. So typically, this kind of motion is not going to bother it. The flexion of the back, rotation of the back can be problematic. But, yep, good question there. Whoops, going back. Those were some of my favorite books. Most of them are on the table up here. Podcast, Not Your Mother's Menopause. Fiona Lovely, she's a little foul-mouthed sometimes, I love it. She's actually a chiropractor that has deep dived into menopause. The Thyroid Fixer, this is Ellie actually I don't think you told me about this, but after seeing Ellie and her deep dive into thyroid, I was like, I want to learn more. This gal was pretty awesome. The Drive, Peter Attia, he just had some great guests on there talking about the basically criminal actions of the FDA by limiting access of estrogen to women. And Dr. Rachel Rubin was up on the stage when they took away that warning just the other day. She's a urogynecologist, huge advocate for women. So see a few people writing, so I won't change that quite yet. And there's a ton more. A podcast for me, I have to like the voice of the speaker. This is probably a perimenopausal thing too. If they have an annoying voice, I can't listen to them no matter how good their information is. But those are all ones that I've really enjoyed. Instagram, so Kelly Casperson also was up on the stage. I love Dr. Stacy Sims. She's a physiologist, really targets the menopausal age group. She's a trainer, I have one of her books up there, I believe. It's basically how to work out through perimenopause and menopause. Rachel Rubin already mentioned. Dr. Men is awesome. She's an OB-gynecologist, got breast cancer while she was in residency, and is now back on hormone replacement. So she's a huge advocate for, I'm 30 years old. I still want to have babies. That requires me to have intercourse. So she could not deal with the side effects of the reduction of estrogen in her body from previously having breast cancer. Dr. Mary Claire Haver, she's a menopause educator. Big Time Adulting's hilarious. She's really foul-mouthed. If you don't like cussing, don't listen to her. But she's from Boston, so she's got a Boston accent. She's now goes to MIDI Health, so I think she's actually lost a little bit of her edge because she's actually getting treated for menopause now. So she's a good time before that. So upcoming events, I am super thrilled. I'm going to hand out some flyers. The ink is not even dry on this yet. We just signed everything yesterday, but come January, there's going to be a new performance center in Woodland Park. There's a local trainer, Justin Collin, Grit to Greatness. You may have seen him around town. He and I are partnering up. I'm going to have office space in his facility. So there's definitely be a weightlifting for osteoporosis course coming in January. So if you guys don't mind, you can take one, pass them around. But he literally signed the lease yesterday, so I wasn't allowed to say anything until this morning. But there's a link to his website and such on there. So the idea behind this is not going to be just a gym. It's going to be a performance center where you can work one-on-one with trainers. I'll be there for the pain issues, the PT aspect of things. I'm pretty excited about having a different offering for you that you don't have to go down to the Springs for. All right, any questions for me?
I have one question.
Yeah.
So it was back several slides ago.
Sure.
But it was the one that was talking about, you said like after 10 years symptoms. So is that after 10 years without treatment, symptoms kind of calm down? Do you remember
Yeah, well,
something?
you're technically in menopause at that point, and usually most
Okay.
people will see that change in like those wild fluctuations of the hormones causing all these symptoms that go along with it.
Okay.
So yeah, so there's hope after 10 years. 10 years is a long
Yeah,
time.
because I know, because the perimenopause for me was terrible.
Yeah.
The wicked hot flashes, night
Yeah.
sweats, blah blah blah. But I'm almost 2 years now post-menopause.
Uh-huh.
And I have seen it.
Yeah,
go down.
improvements.
So I guess kind of my big question is hormone replacement strictly for symptoms, but then there's other
No.
benefits.
Yeah, and
too,
Ellie will
right?
deep dive
Okay.
into this, and that
Okay.
reminded me of my other example. When is too late for hormone replacement? After my success with Ellie, my mom was like, who'd you see? She lives in North Carolina. She found a functional med practitioner there. And my 80-year-old mom got put on estrogen. She had really bad arthritis, crippling pain from it. She wears a patch, the low dose patch, and she's like, I cannot believe. She's like, I'm still hurt. I mean, I'm 80. She was a gym teacher. She was super active. But she said the flares are not nearly as bad. The duration of pain is much less. So yeah, never too late for addressing some of those inflammatory side effects.
Yeah, because I guess I kind of read and a doctor had told me like at 65.
Mhm.
You typically go off then. So is that just pure?
Gosh.
Yes, so that would be
A myth.
yay, you found someone that would put you on it to
Right,
start
right.
with. These hormones have been in our body our whole life.
Right.
There's not a reason to come off it. Because if you come off, guess what happens?
Everything comes back.
Yeah,
Okay.
yeah, for sure. So it is finding the provider that will allow you to do that. I probably ran way over, so I'm going to quickly say a few things. First, we offered a little giveaway, which was a $100 gift certificate to Boards and Barrels. So my sneaky way of keeping it totally random, if you will reach under your chair, you should feel metal. If you feel paper, you're going to be the lucky winner. So everybody reach under your chair. I think the main person that needs to reach under her chair wasn't reaching under her chair. I was watching you going, reach under your chair. Yeah, so, dinner. sure, on us, for sure.
great.
We're gonna take a good like 15-20 minute break.
Wait,
we
can we
want
make that like a 10?
a 10-minute break,
Yeah.
sorry. Okay, so bathrooms are in the back, drinks, and please, Miss Susan, who brought all her lovely skincare products here, would love to chat with you. So take a little time to stop by your table while we're
I think Susan's
in a
gonna
break
step
here.
to the front and
Oh, you're
say
gonna-
things. Yeah. If you guys want to meander, there's yogurt, there's nuts, there's water, coffee, bathrooms in the back, so get refreshed.
Hey everyone, I'm Susan. I'm a nurse practitioner for the past 10 years. I was practicing in family practice, and about a year and a half ago I started to specialize in skin health. I've been so passionate about the skin forever, and so now what I do is help you get your very best skin possible. And we go through a lot of change kind of midlife, during perimenopause, menopause. Estrogen levels are declining, and that affects the skin pretty dramatically. We might even wake up one day and just feel like, oh my gosh, how did I just age 5 years overnight? And so, you know, skin thinning, dryness, sagging, more fine lines and wrinkles, it doesn't feel good. And so I'm here to help you figure out what products are going to give you the most bang for your buck and really help transform your skin and get it revived. And so I have a table back there. Feel free to stop by. I'm offering complimentary skincare consults. If you haven't signed up for one, please feel free to do so. I offer mobile services in Woodland Park in Colorado Springs, and I also have a home office in Woodland Park. So I do have to leave a little bit early, probably 11:45 or so. I'll be packing up, so please feel free to swing by. But if we don't connect, I'll leave some of my contact information on the table there. But yeah, so
Thank you.
thank you very much.